L'Oreal Physician Assistant in the Department of Internal Medicine, who's also a member of our diabetic care team. Nurse practitioner in the Department of Medicine, who's also a member of our diabetic care team. Ann McBain is a registered nurse who's a certified diabetes educator. Rachel Maida is an assistant clinical professor at UNE College of Pharmacy, a clinical pharmacist here at Intermed, and a certified diabetes educator. And I want to thank everyone for coming.
Great. We're going to get started with Angela Tilson's going to start. We have 3 cases. Any questions along the way, please don't hesitate to ask, and we'll get started.
Okay, so we've got a pretty packed here in slides, so we'll see how much we can get through, and obviously we want people to interrupt and ask questions, so let us know. But these are our 3 main objectives today. Select appropriate non-insulin pharmacotherapy in a type 2 diabetes patient based on specific case findings. Second, describe the role of insulin in management of patients with diabetes and select an appropriate regimen, including starting dosages and dose titrations. And then understanding the role of our continuous glucose monitoring for assessing glucose control and modifying pharmacotherapy in patients with diabetes. And those are pretty much going to be outlined in 3 separate case studies, and then we'll have some content after that as well. So first up will be Dr. Ervin.
First of all, I want to say welcome to all these people in my diabetes team now. It's a far different scene than what we've done in the past. And Lori and I used to work and try to do our best to support you and especially our patients, but we have so much more help now, and the help is better, and we've all gained knowledge and support from this crew, and so make sure you use them because we're very lucky and our patients are very lucky to have this crew with us now. Okay. This case, 50-year-old male with type 2 diabetes for about 7 years, A1C between 8 and 9 for the entire time that he's had diabetes. He's been metformin from the beginning, 1,000 twice a day. His BMI is 36. His weight is 278. He had a peptide done. It was 6.8 when all things started. An MI 6 months ago. Additional medications are Crestor, aspirin, and lisinopril, and then he came to see me for the first time. I ask you at this point, what do you think is this guy's biggest problem? Is A1C of 8 to 9, or is it a BMI of 36 and a weight of 278? As it stands right now at Intermed, there's metrics for which if I can get his A1C down below 7, Intermed and I get paid more. I get paid anything to help him get his weight down from 278. Next slide. So 80% of patients with type 2 diabetes are obese. If I said I'm going to take this guy's A1C down to 7 in a hustle, I put him on a sulfonylurea, a TZD, insulin, some of those, and I know I could do that right away. It would probably go from 288 to 295, and I've done him many huge favors, but Intermed looks a little bit better with the metrics. So nice now to have some options, and I'm going to go over some of these quickly. The incretins, the GLP-1s, and DPP-4 inhibitors, the first 2, are from the incretin family, and basically they work because of GLP-1, which increased in secretion with PO intake of fat and carbohydrates made by the alpha cell of the pancreas and the small gut, and it increases insulin secretion that is glucose dependent. So it is more readily secreted. It decreases your amount of glucagon, which further decreases blood sugar. It tells the stomach that it feels fat, so there's this feeling of satiety, and it's this effect too that says you shouldn't eat it anymore. So the fact is, the bottom line down, and people don't want to eat quite so much, so that you have a decrease of A1C between 0.5 and 1.8, a weight loss on the average of 2 to 5 kilograms. For inhibitors, basically in the body, once GLP-1 is active, DPP-4 comes in and knocks it out and makes it inactive. or you can take a DPP-4 to make your GLP-1 work longer. So the activity is the same. It's not quite as efficacious. So you decrease A1C between 0.5 and 1.2. The weight loss is not so great. For medications and your handouts, I don't know if they're handouts. There's a whole list of all these medications, so I'm not going to go through them all today, or we wouldn't get to the next case. Okay, there's the SGLT2 inhibitor guys have heard about there. They basically work by decreasing your ability to absorb glucose in the proximal tubule. So you have glycosuria, which leads to weight loss, and it does. And if you urinate out some sugar, your A1C goes down as well, from about 0.5 to 0.8%. There's some idiosyncrasies of this family, and that's that GRN increases cardiovascular mortality and heart failure in big studies. Don't ask me why. No clue why it has a favor in this family. And at the same time, catechol and invokana increases the risk of lower limb amputations. So I don't know whether this is population-based in the studies that have been looked at. No one has an explanation for it. Two almost identical. We've studied them both here. I don't get it. But so I would think of when you use them, if you want to, is in a patient who had lower limb amputations previously or clear vascular disease at lower extremities. I may stay away from this family in general. And metformin we've been using for years. The weight is essentially unchanged. Your patient who's obese, you want them first to have intensified lifestyle intervention, and nothing is more important in the treatment of these patients than this. And in every pod you have a nurse practitioner that you can go to and send this patient to. It's not, Ms. Jones, you need to eat better, exercise, got that? Send them home, and that's what I used to do. But these are so much better than I am, and they follow up and follow up and follow up. I encourage you to make sure you do that and don't stop with you ought to eat less. So this I got when he'd had that apparently, but probably not. Metformin, and so then it looks like I would go with a GLP-1 and possibly a SGLT2 inhibitor. And if you still want to work on weight, there's weight loss medications. We've actually done some research. I'm not a fan of any of these weight loss medications, to be perfectly honest. But we done some research using Belviq, and Deb Fuchs-Ertman was the chief investigator. What kind of weight loss and A1C improvement did you see there?
So we're into about over 4 years with the study, and really a couple pounds at most. A lot of people will gain it right back. And this study has like support people use for diet.
The list says you should get maybe an A1C loss of about 0.5 with the use of glucosamine or Belviq, and pretty much all of these have some. But their side effect profiles are a little bit iffy and scary. And in fact, when we've looked at this, we don't see a lot of weight loss, and we don't see a lot of A1C reduction. And so I'm not sure anybody wants to step into that part of this particular algorithm. Next slide. Started on liraglutide, which actually now, that's a GLP-1. These injectables, the GLP-1s right now. There's an oral one out soon. And FDA has now approved it for weight loss independent of diabetes. So there is some weight loss from this medication stuff I talked about. As I started them on SGLT2 GLP-1s, 10 a day, the one that has some cardiovascular protect perhaps. And I put him up in 6 months, and his A1C had gone down to 7.6. His weight had gone down from 278 to 264. It's not a huge weight loss, but in the patient population, it's always big. If they see, and I'm sure you've seen this in your practice, a big person will come in and they'll say, I'm down 3, down 4, and then 62, and you say, really, are you kidding? You care? But they care. And if they go up, then they don't care. And so just a small step, a small step, a small step. And so it helped his sugar. I'm down to my metrics, so I get paid by Intermed. He's be happier, and I think he'll stay with the plan better. So trying to bring this out to encourage you guys, these populations of medications are not that scary. They really work. And because 80% of these people are fat, don't go ahead and just immediately put them on things that you're totally comfortable with, and a little fatter, and they'll probably fall off the wagon a little quicker. Questions? So your handbook, there's a whole list of all these different medications. GLPs are injectable, DPP-4s are by oral. Any questions, call these guys, team, to go ahead and help you get them started. If you have any discomfort, any wiggle, just like the thought of it, give us a call.
Bill, is there much in terms of data with combining those two agents now? When I looked at it, I didn't see a whole lot of large studies with those two agents.
I have a combination meta-analysis of what the average weight and A1C are. I have several people on this combination now. I don't see the addition of one can decrease by 1.2, the other by 1.2. I don't see him going down 2.5 and 3. I see him going down 1.5, about like this. He had A1C 8.8. He went to 7.6 on both. I'm not afraid to start both. Sometimes starting medicines at the same time is iffy business. So they get a little sick to their stomach or they don't like how they feel. I don't know which one to stop. So I don't always recommend.
Okay.
You're up.
Thank you. I have a case. I met this gentleman a couple of months ago. 62-year-old male, had the referral come from family practice urgently, A1C 10.4 in June, and he had been getting progressively worse. I took history. He said he was diagnosed about 10 years ago with diabetes, remembers seeing a dietitian in the past, doing formal carb counting, talks a little bit about understanding that he needs smaller portions, and this is what he was currently on when I first met him. His metformin maxed pretty much therapeutically at 1,000 twice a day, and glipizide, 110 milligram tablet in the morning, but he had also been off of it temporarily and then back on. And he wasn't testing it all at home. His meter was old and said the battery was dead, so he wasn't really sure what his blood sugars were running day to day. He recalls taking glyburide in the past. He's never had any other injections, whether GLP-1 or insulin. Hadn't tried any of these other oral agents either, so just metformin and glipizide and or glyburide. When I ask him how he's feeling, initially he says he doesn't feel badly at all. If I ask him specifically about maybe some diabetes symptoms like polyuria and polydipsia, he does say, yeah, actually I have noticed that. And by the time he got to me, he had lost 1.2 pounds, but if I tracked him back 6 months, it had about a 10-pound weight loss, and his BMI was just over 26. Nothing significant as far as other complications, no retinopathy, feet feel fine. He is doing a little bit of exercise. And when I ask him, how things are going just in his life in general, he says he's on the road a lot, he's overnight in some hotels for work, and then, oh yeah, my wife is really sick, which was a huge component of our initial visit. He was explaining to me that that's pretty much all consuming right now for him. So I took a food recall, and I know my diabetes team members will agree that we try to do this very carefully, and I won't read it line by line, but you can kind of see that, it's very specific in what he's doing, telling me, and how he's not cooking, and his wife was cooking, and now he's going to the corner store and getting shepherd's pie already pre-made. And I think it's important just to note that medication is only one piece of the puzzle, and exercise, activity, and food intake is another piece of the puzzle. So I really wanted to kind of get at the heart of what he was doing on his own before I tested anything. Here are his other meds, pretty standard, a statin, some vitamins. He wasn't really using the lorazepam, but he said it was there for anxiety if needed. His vitals look pretty good. Like I said, his BMI is just over 26. I was teaching him how to use a one-touch variometer in the visit, so he happened to do a random glucose check with me, and he was 279, and he thought he was about 2.5 hours after his leftover lunch of the shepherd's pie. Exam good. Here, A1C we talked about. December last year, he was 8.9, a little bit lower. Triglycerides have been up and down. I mean, obviously globally up, but maybe A1C, I'm thinking. Looks good. And some also done a type 1 antibody, a GAD65 antibody test on him in 2009, which was negative. So that was good to know. So we think, I'm kind of a little hint here because I'm kind of putting up, but what would you do? There are no wrong answers. So I'll keep clicking, but any of these, right? Any preferences? Any picks? Any that you would prefer or another? What do you think about what he's already on?
Do you think his weight loss is because he's eating shepherd's pie or not eating, or you think that's related to his diabetic control?
So in our first case, right, our BMI was a lot larger, more elevated. This case, he's just over 26, so I think I was curious about his weight loss, especially over a 6-month span of time if he's been running higher blood sugars. So in my mind, he wasn't testing yet at home, so I focused on that first. And when I started to do a little bit of light carbohydrate counting education with him, he was really engaged in it. He wanted to know a little bit more about what he can be doing right now, especially with the foods he's already choosing. So a lot of the times I'll call this meal makeovers, like, okay, this is what you're choosing, but how can we make it better? If you are buying that shepherd's pie, can I use the plate method and make it only one part of your plate and maximize your salads and veggies and other things? He was very receptive to this, and in the meantime, I ordered a C-peptide on him because I wanted to see what his beta cells were doing, especially with the weight loss, like Dr. Ervin is saying. He was agreeable to increasing the glipizide to the therapeutic maximum just to see if that made any difference between the two appointments. I did make a note just to be specific about the timing of these meds with breakfast and supper versus bedtime. Just not really helpful if you're stimulating the pancreas at bedtime with your glipizide. And I come back. So here he is coming back, and he shows me some numbers, and they're not all 200s, but they're not great there. So he kind of gave me a rundown of what was going on. He did lose a little bit more weight, but he definitely said he felt better. So that was good. It'll still look good. And here are his C-peptide results, which you guys might notice in some of our notes. We use something called this HOMA calculation, which is the homeostatic assessment. You can go to the website, but if you plug in a fasting glucose and a C-peptide, which is that insulin marker that's coming off of those beta cells, you can get a percentage of exactly what their beta cells are producing. So 16%, I sort of looked at that like, well, you're not really making a lot. And again, he was really receptive to that information. I think he was validated that it probably wasn't going to match what he did. I think and that's what I did. So any of these options, if you hadn't done the C-peptide, you might have gotten a little bit more out of that pancreas, but in this case, because I had that information, I went ahead and I started him on Lantus. So I picked one of our basal insulins. We'll get a little bit into the dosing, but I did his dose based off his weight, 0.2 units per kilogram. Kept him on the metformin and glipizide, and my thought process with the glipizide is if I was just starting basal insulin, I didn't really want to pull the rug out from underneath them, so I kept the glipizide on board. Versus starting maybe a basal regimen, I might have stopped the glipizide with the bowl insulin. We talked a little bit more about lifestyle modifications because I started insulin. I wanted him to come back in 1 week. He comes back. He's pretty good. Gave instead of maybe why he had a couple of the highs, maybe some things he's eating at night, but overall much improved. So, and again, the weight also rebounded in the right direction as far as what he was losing. Now, we don't want it to go too far the other way, of course, but I sort of took it as a win and said, let's get everything going the way we're going, and we'll see how you're doing when you're due for your next A1C. And that over 10 A1C is now a 7.6. And I again the other day, he's doing great. So I don't know any questions specific to that. I know we have a few other slides in a little bit specific around insulins, but I think just comparing to Dr. Ervin's case, again, when you see type 2 on the problem list, you can choose from a whole list of agents. I think maybe honing in on certain parts of the history. If you suspect maybe there's an insulin deficiency, it might sway you towards insulin instead. He's going to talk to us about how we're using CMS in our favor.
I just don't understand, but why do people that was, I just don't understand, like, the pathophysiology.
Yeah, that's a good question. Do you want to answer it? Do you want me to answer it? I think the thinking is over time that those cells will just get tired. So even if somebody doesn't have positive antibodies and GAD65 and all that, I think over time, if you're dealing with insulin resistance where the pancreas is saying, I need to get out more insulin, and it just can't keep up with that demand, you'll start to see those beta cells sort of burn out like little light bulbs, and it's really hard to turn them back on. That's where I think a lot of the research is right now. So people will sometimes come to you and say, oh, yeah, they told me I started out as type 2 and now I'm type 1. It's not necessarily that they have antibodies all of a sudden, but it's that dwindling supply over time where the pancreas gets tired.
What was insulin production calculator?
Yeah, it's called, if you Google the HOMA, H-O-M-A, and actually these slides will be available, right? So I put the website right on that slide, and Mitch will like this, but your IT person can put the calculator right on your desktop for you if you want it. Yeah. Sorry, Mitch, I'm so sorry. But yeah, you can do that. And sometimes, Lori and I will notice that people have their C-peptides done where, you can order things. If you don't get a glucose with it, you'll get that reference range. Sometimes it's a little deceiving because it might look like, geez, that C-peptide, looks pretty normal, but their glucose is actually high at the time of the test. Those beta cells should have been cranking out more, and they couldn't. That'll give you insight to that. Those are good questions.
Great, thank you. Yeah. This case really is just explaining when you've done everything as in case 1 and 2, you can look at some other options. This is a 65-year-old female, BMI of 38, hemoglobin A1C of 8.9. This is what we typically see when we see patients come in and they say, okay, I've just been up, my hemoglobin A1C is elevated, what do I do? Yes, they have hypercholesterolemia, hypertension, depression. So when we start to think about what can we do, we really have to have something that's powerful. Because I've already seen you've already made many changes. They've seen a local dietitian, they maybe have a personal trainer, they've gone to the gym, they've done all these things. So they'll get a glucose log. When you look at it, it looks pretty good. You're like, okay, so you're trying to help the patient. I feel like it's really motivational targeting, trying to get that patient to see I have to take care of myself. So I get this, and I look and I see that I've gone through the chart. I look and see that he's had all kinds of medications. None of it's working. He's gained weight. I start by suggesting a continuous glucose monitor because I want the patient to actually see what's going on. You can go to the next slide. Mm-hmm. So those blood sugars that you just saw weren't that bad. This is what the continuous glucose monitor revealed. Well, first off, sometimes what we do is see a patient, they come in and their fasting blood sugars are 108, 98, 120. So you're thinking, okay, what's going on? Do you increase Solantis? Obviously, you cannot increase their long-acting insulin because their fasting blood sugars will continue to drop. And it was every time they were taking their blood sugars was when their blood sugars were good. They weren't seeing how high they were getting. So that was in turn directly related to that higher hemoglobin A1C. So sitting down with the patient, them seeing this graph and going through their food logs, their medications, when they're taking their medications, how they're taking it, making sure it's not metformin at bedtime, making sure they're not taking their insulin after they eat their meal, their time insulin. Looking at it, is that the type of medication that's good for that patient? So when you know that when we're in your patient and seeing them for 30, 45 minutes and we're going over this, whether it be, like I said, food log, insulin, we're really trying to find out what are the barriers and what can we help. He comes back 4 months later, they're down, because now they're not just taking the insulin whenever, oh, I ate the spaghetti dinner, I'm just going to give myself 20 units, I'll be good to go. Actually, I taught them how to carb count, how to take their insulin. Don't give yourself more insulin, you're going to gain more weight. So it went down, the hemoglobin A1C went down. But if you look, the actual blood sugars look the same as did in the previous slide, because now I'm actually looking at true blood sugars. When they're taking it, are they taking it 2 hours after they eat? Are they taking it before they eat, bedtime? And this slide, there's an A1C. I do another continuous glucose monitor, and I'm actually getting a true reading. So that hemoglobin A1C is a true reading of what's going on. And I feel like I have gotten the patient to buy in to this is what your health is, what your medications you're taking. I don't want to give the patient more medication. And I want the patient to be able to feel, now that they've seen this, I feel it really does power. Patients feel powerful, and then once they have that information. So questions about that? View.
If you go back to the first slide on your presentation, just look, we've all seen people come in with your little log, and they probably aren't this good of a log. They might have one in the morning and one at night, intermittently over the last month, and they kind of like that. And then you look up and you see the A1C at 29 or 9.2. This happened to all of us, a million times. And we just say, you're doing it right, but we're not exactly sure. I think this tool is so important for us to sort of dig out, instead of making another mistake with what you're going to do next. These guys, the continuous glucose monitors, actually make it so precise to know they're eating their way right through their problem. You know, it's not you, it's the patient. Or in this case, it's the patient who's doing something wrong because they didn't know they were doing something wrong. We have to use these things. We've got 5 of them, and they're pretty cool when they come out. And the writing is right clear that from the beginning, this person was the very best time of the day, and oftentimes over the course of my 5 years of doing this, these are totally wrong. They're fictitious. They just make them up and bring them in. And say, here's some good ones. Are you kidding me? This is really cool. And then you say, let me see your machine. And they say, I don't have a machine. So it becomes quite clear that this is a tool either to bring out the criminals in your practice or the fact that
This is our new marketing, the lie detector test.
I got to change the tune of this thing, you know? It's got to be exacting a little bit. But anyhow, it's a great tool, and they have the other part is that when you send patients to these guys, did you read the history about the type of pudding they were eating or shepherd's pie that they bought down at the store? I would never take it. Take the stuff that is so meticulous, they can get into these people's minds. Like, and most of the providers in this room and those that are probably listening or not listening never do that. So use these guys because they're incredibly good when they work their way through the case. I'm done.
You can go to that last slide.
You want that again, or you all
Nope,
set?
go ahead. I just wanted to... Before Angela starts off with just some information about insulin, it's about, we're now using, in your packets that you'll see, there's so many new medications. Actual attest to trying to really help our providers learn about long-acting insulin, how to use it, when you would use Trudeau over Lantus or Tresiba over Levemir. It's about here, a lot of patients in the donut hole with to calculate whether they get insulin from Walmart, was the NPH in regular because they can't afford, or their insurance will no longer provide that insulin. So we have patients who have been years of taking a long-acting and mealtime insulin that no longer can afford it. They will stop their insulin. So Walmart offers $4.88 per vial of insulin. Yes, it's going back to the old way. It's NPH, regular, but you have to really explain to the patient it's a different type of insulin. They can't take their mealtime right before they eat. So we're having patients come in. Once we can at least explain it to them, they can get into it, we can educate them, I think we're going to have more success because, one, they will take their insulin. They can, at least it's a lot cheaper, and understanding how to use the insulin. So please, any questions, don't hesitate to reach out to Rachel as well.
And also, just kind of getting back to maybe looking at do insulin calculations. These came from the ADA standards of care this year, but pretty much still 0.2 to 0.4 units per kilo. In some cases, maybe 0.1 is still acceptable versus 0.4, and I think it all depends on if you're suspecting somebody to be insulin deficient. Certainly our type 2 overweight insulin-resistant patients can stand to start a little bit on the higher end of these dosing calculations. And then bringing the patient back fairly quickly after your insulin start or calling them, depending on your preference, but seeing if you can start to treat to target by going up or down 10 to 20%. If you've started kind of on the low dose end, you would probably expect to be titrating upward, of course, so that you're starting low, going slow, so to speak. And these are our targets that we're currently using, but also just to make note that these can also be adjusted based on age, comorbidities. We certainly don't need an 85-year-old patient targeting a fasting to 90. You might select 100 for her or above, so it can all be adjusted. In your packets, we did include all of these tables since it's a little probably more intensive to go through line by line. But these first couple are our basal insulins, and I think this is probably where we've had maybe the most change in the last couple of years. You'll start seeing us talking about Toujeo and Tresiba. So these are our more concentrated insulins, Toujeo being U300 and Tresiba having the option of a typical U100 or U200. So what that means is that you could dose somebody, coming from Atlantis, 50 units at night, you could give them Toujeo or Tresiba and keep it at 50 units, but you're going to get less volume. So 1/3 of the volume with the Toujeo and half the volume with the Tresiba U200. Think that the skin may absorb a little bit better if you're giving less volume of insulin. And then both of these, as we've listed here, 36 hours, you've got a longer duration. You're still dosing it once a day, but if the patient is really having a difficult time taking their Lantus every night at 9 p.m., this would be a little bit more forgiving if they're adjusting that. Yep.
We just finished comparing Lantus, Levemir, and Toujeo here in a minute. It's part of a national international study to see if there was any benefit of versus the next versus the next. Currently taking, currently taking 3 of the 8 available long-acting insulins that we're checking, but one of these insulins, their particular maker pharmacy has to say one is better than another for a particular reason. And so the whole thing is to prove that yes, one is better than the other, or to say no, there's really no difference. What take 0.5 cc's or 1 cc, you still get 1,000 units or 50 units each time, whether it's concentrated or not. Or maybe there is a difference. So we're trying to figure that out here. Anyhow.
I think in doing this presentation, Lori and I kind of talked about that. We've switched people before, and we've seen great results, and we've switched people and seen no results. So it's a little bit science, but a lot art, trying to just tend to some of these and just see if it matters for a particular patient or not. And honestly, cost and formulas drives a lot of our decisions, unfortunately. So it all depends on what's covered. So I have some bolus insulins. I do want to mention that we've had our extraordinary CDE, Angela McBain, working on these tables and going around to all of your CAs and going over the calculations on how many units are in these vials and how many units are in the pens and how many pens are in which box and how to do these prescriptions. I don't know if you want to comment on anything. But she's done a great job doing all of these little lunch and learns to help your CAs do these prescriptions.
I was asked not too long after I started, it kind of became apparent there was a theme that there was difficulty calculating prescriptions adequately and accurately for all new diabetes injectables. It's very hard to keep up with concentration. There's different amount of pens per box, and the pharmacies want to break up the boxes and so forth. So the learns have consisted of providing a formula for CAs to use in addition to the tables to calculate based on a maximum total daily dose, which keeps both the pharmacies and the insurance companies happy and gives the patient enough. The last reason we want their blood sugar running high is because we didn't provide them with enough insulin. So together the tables, and that will be helpful to the CAs and hopefully providers as well. And then the insulin expirations and insulin actions, just asked to put together because it does vary and it's hard to keep track of.
And our aware that we're really trying to avoid insulin errors because a lot of insulin errors happen, especially with the prescriptions and certain prescriptions not being completed correctly. So we have been, Angela and I have been going to family practice and talking with providers just to make sure that they do understand when it says the maximum amount of insulin, you're calculating it, your CA or RN will send you back that telling counter so that you can review it. There are a lot of CAs, RNs, LPNs that are very scared about having to be the last person to timestamp that telling counter. And it is understandably so because if somebody is on 100 or 200 units of insulin, they're going to make sure that that is correct because we have had some errors that patients thought they'd taken short-acting at bedtime and vice versa. So we're really trying to educate everybody to avoid those errors.
And Lori sort of touched upon already the low-cost rely on brands at Walmart, so I'll kind of skip through these really quickly. And they are in your packet. We did include some examples on how maybe you would convert somebody from maybe just Novolog to NPH and rely on regular, and just some nuances as far as if the person is type 1 or type 2, maybe how you'd want to dose calculate those. Again, we're your sources if you need help with that, but we did include this in your packet just in case you wanted it. And I think we have just a few minutes left. I'm going to turn it over to Rachel. Rachel made some slides on our non-insulin agents. And if you have any questions in these last few minutes, just let us know.
And when it's done, you have to stay.
We're doing good.
Okay.
Really brief, I guess. So this is a chart of the GLP-1 and a few things to point out is basically some of the main differences between them is their dosing regimen. So I think one of the main ones that we usually go to is Victoza, and that's because it's a once daily dosing, and I find that adherence is often better when we compare that to even a weekly dosing. So Victoza is also shown to be one of the largest as far as its weight loss benefits. So you'll see most of us kind of go towards Victoza as a first, but this may vary depending on insurance as well. I will know that Victoza does have the highest incidence of nausea, but this can really be limited with appropriate titration. So it's really important that we start it off at the 0.6 milligrams once a day and do that for a full week before we go up to 1.2. And if we have really sensitive people, I've even done things such as have them go to 0.6 for a week and then do 0.6 plus 5 clicks. 10 clicks in between each dose, 0.6 to 1.2, there's 10 clicks. So you could even do 0.6 plus 5 clicks, then plus 5 more clicks to the 1.2. So the slow titration, just like metformin, is really great for reducing that incidence of nausea. And it's transient, so it will go away after about 2 weeks to a month. So if we can just counsel them on that and let them know that it will go away, we usually find that they will stick to it and adhere to it. So I guess the other thing, I won't go through the TZDs, we don't use too much anymore. It may be appropriate for some patients, though, in the absence of heart failure. Sulfonylureas, really kind of trying to get away from the sulfonylureas, if possible, just because of their weight increase effects. Also, we do find that after about 5 years of use, their efficacy is not great. So after our patients have been on them for about 5 years, they're really not that beneficial and still causing the weight increase issues. And also, I will say they're all clear renally. So once our patients are getting into 65 years of age or older, they are on the Beers list because they're excreted renally. Glyph-ibride has active metabolites, so it can really cause hypoglycemia in our elderly patients and put them at risk for falls. So that's something to think about. The major thing I wanted to talk about with the SGLT2s, because I see this a lot, is that they actually do have a significant blood pressure lowering effect. So they decrease blood pressure by about 6 milligrams mercury systolic. And one thing to think about is if you are putting them on it, it's good to get a baseline blood pressure, and you may even, and we have had to titrate them down on some of their current blood pressure medications. So one of the most common complaints we get about the SGLT2s is dizziness or hypotension. So just keeping that in mind. And I find that if we can prevent these in before they onset, then the adherence is much better and they're much more effective, and we can keep our patients on them. So these, of course, are inappropriate in someone that has CKD because they are totally cleared renally and not they work. Anything about those agents? No?
Diabetes Awareness Month. Those are all the things our patients might be thinking at any one time.
Well, I've been asked by Felidia, who's still here, I believe. Basically, you know me as the coding guy that's standing up in front of you most of the time saying we need to get better at our coding and risk coding. And to counteract some of Bill's cynicism, we do not get paid for getting people under 7, Bill. We get paid for keeping people under 9. So that's so understand. So first of all, E11.9 is diabetes without complications. We have far too many of our patients that have this diagnosis. We're not alone. Other local healthcare providers, same way. It is very rare that we have no complications. You may have an elderly patient whose A1C is 6.7%. They're never going to be on medicines. They're simply getting older. Those are people who have diabetes without complications. Can we go next? Gotcha. With diabetes, we want to get to the terminal digit. We want to get past the 10th. We want to get to the 100th. Basically, anybody whose A1C is over 7 and age appropriate, they have basically it's uncontrolled hyperglycemia. The chronic kidney disease and the retinopathy codes are by far the highest risk adjustment codes in diabetes, so you've got to link them. You've got to also identify the stage if you're doing chronic kidney disease. So remember, they have diabetes and their A1C is up and have microalbumin. You've got to keep all of those on your problem list. And don't forget, you have to bring into your note and comment on them at least once a year. So even though they've been microalbuminuric for 10 years, you'll have to address that every single year in order for it to be for that code to be revalidated. A little bit more complex, and again, nobody here is coding experts, but here are some others that essentially your diabetes your diabetics who all end up getting cataracts. Essentially, that is a linked code and risk adjusted. Same with any of the things in the E11.69 category, although none of us are likely linking those right now. And then the circulatory conditions are also very highly risk adjusted. So again, trying to get past the 0.9, that's really what we need to start doing. You don't have to be perfect. They have other things other than just a normal A1C. They may not even be on medicines. Actually, most of these people have extra diagnoses.
Question.
Yep.
Previous. So say the E11.69, this is the cholesterol. Would the diabetes type 2 with dyslipidemia that you can search for again? You have to, it's diabetes type 2 do other specified complications and then also pull over dyslipidemia?
It's actually, it'll code out to dyslipidemia, but you also have to bring over the, what is it, E78.00, which is pure hypercholesterolemia. So you have to bring both of them over, and I know it's a pain in the butt, but you have to bring both of those over.
Type 2 diabetes with dyslipidemia, and then arrow over.
Yes, your hypercholesterolemia. Yep. Basically, using as many of the E codes as you can, basically diabetes with peripheral vascular disease, erectile dysfunction related to type 2 diabetes, and then always try, if your patients are on insulin, please make sure that it's in the chart that they're on insulin. There's not really, Z codes are not risk adjusted, but when we're talking about insulin or their recall or there's a change, because actually what happens is every year, and we just learned this in a Martin's Point patient, that as of January, Martin's Point is no longer going to be covering Lantus. They're going to be going with Basaglar. And so that notification goes out to patients. We all recognize that on January 1st, probably at least a third of your diabetics are going to be calling up and saying, my insulin is no longer covered. They want us to do this. And so that's why those previous charts are so important, because they're not always even Steven, but they're not all even Steven. And you're going to be faced with this because notifications to patients are going to start going out next week for most of the Medicare Advantage products, and they typically change insulin more often than some people change their underwear. So that's everything. So go see patients.
I'm trying to counteract that cynicism of I did just on weight loss. You know, that's